Morning. Today's topic is root resorption. Coming to the introduction, root resorption definition. It is defined as a condition associated with either physiological or pathological process resulting in the loss of dentin, cementum, or bone. So this definition was given by American Association of Endodontics, 1944. So resorption is basically multifactorial process which results in loss of tooth structure. And due to different cause, it may vary, leading to several types of resorption. And resorption of buccal or lingual surface usually it is not seen until the 20 or 40% of the tooth structure has been demineralized. So there are various classification of resorption. So the most popular one is given by Linscomb, other one by Andreasen. So the Linscomb classification of tooth resorption, it is broadly divided into trauma-induced, infection-induced, and hyperplastic invasive resorption, and they are subdivided into various other kind of resorption. And according to Andreasen, they are broadly divided into internal and external. Internal include root canal replacement resorption and internal inflammatory resorption, whereas external resorption it is further subdivided into surface external resorption, then inflammatory resorption, replacement resorption, and dento-alveolar ankylosis. And there are two prerequisites for resorption. That is, first one is a loss or alteration of the protective layer, which includes pre-cementum or pre-dentin. Second one is the inflammation of the unprotected root surface. So these two are the prerequisites for resorption to occur. Then sequence of events leading to root resorption. First one is crushing or damage to PDL. It can be due to any traumatic injuries like luxation, subluxation, etc. Then after this crushing or damage to PDL, there will be loss of protective layer like pre-cementum or pre-dentin layer leading to denudation of root surface. Then third stage, chemotaxis of hard tissue by resorbing cells. That is the third stage or third sequence. Then macrophages and osteoclasts remove damaged PDL and cementum. This resorption occurs. And there are various cells which are involved in resorptive process, which include odontoclasts, dendroclasts, osteoclasts, cementoclasts, monocytes, and macrophages. And mechanism of tooth resorption. So there will be activation of rank-rankle system. And OPG. OPG is considered as an opposite to the resorptive process. That is, OPG stands for osteoprotective, and this is against the resorptive process. So what happens is rank green one, that is a rank, it has a receptor, and this receptor will be bound by rankle. So when this rank bind with rankle, resorption will occur. And OPG can act as decoy receptor because it is structurally very similar to rankle. So it acts as a competitive inhibitor for the resorptive process. So whenever OPG combines with rank, resorption will stop. Whereas when OPG concentration is less and rankle is more, rankle will interact and cause resorption. That is, initially it will activate the osteoclast. Initially, precursor osteoclast will be present. So when rank-rankle interaction takes place, this osteoclast precursor will be differentiated to active osteoclast, and actively bone resorption will occur. Whereas OPG, that is osteoprotectin, is against the resorption. So whenever OPG is increased, bone resorption will be less. Similarly, PTH stimulates bone resorption like rankle and PTH stimulates bone resorption. OPG decreases bone resorption. This is a mechanism of tooth resorption by the activation of rank-rankle system. So there is a bimodal process which explains the resorption, which include degradation of inorganic crystal structure. So this degradation basically takes place in an acidic pH. That is pH whenever it is less than 5, that is around 3 to 4.5. This resorption can occur, and this is initiated by an enzyme called carbonic anhydrase 2, that is Ca2. So this converts CO2 and H2CO3. All this take place intracellular area. And also enzyme acid phosphatase also favors resorptive process. So this is a first method of resorption in a bimodal process. The second one is degradation of the organic matrix, in which 3 enzymes will be involved. That is collagenases, that matrix metalloproteinases, then cystine proteinases. So collagen is an MMP. This acts at pH of 7, that is neutral pH, whereas cystine proteinases will be more active in the acidic pH. So this cystine proteinases secrete what enzymes to clear zones through the ruffled border. So these are the bimodal process which include degradation of inorganic crystal structure and degradation of the organic matter. That is why it is known as bimodal process. Now there are various protective mechanisms against resorption, that is anti-resorptive mechanism in our body, which include remnants of epithelial root sheath, then OPG, that is osteoprotectin, then osteoclast. Osteoclast do not adhere, that is osteoclast usually does not adhere to non-mineralized collagenous matrices. That is again a protective mechanism. So anti-invasive factors like low molecular weight proteolytic activity inhibitor on root canal surface again act against the resorptive process. That intermediate cementum is also a protective mechanism. Then methods for controlling osteoclastic activity include calcitonin, tetracycline, medications like glucocorticosteroids, calcium hydroxide, bacitracin, neosmycin combinations, stannous fluoride, bisphosphonates. All this act against the resorption, or it controls the osteoclastic activity. And there are various factors regulating the resorption, which include local factors as well as systemic factors. In systemic factors, there can be hormone like parathormone, which increases the resorption. Again, vitamin D3, calcitonin, all this increases resorption. Whereas local factors like noxious stimuli, then macrophage colony stimulating factor, interleukin 6, 1, TNF alpha, prostaglandin E2, bacterial toxins. All these are local factors regulating tooth resorption. And they're the agents increasing the resorptive process. Then coming to the classification, I have already mentioned that, and Andreasen classification, there are internal and external resorption. So coming to the internal resorption, by definition, it is an unusual form of tooth resorption that begins centrally within the tooth, apparently initiated in most cases by a peculiar inflammation of the pulp. This definition was given by Schaefer. So the clinical features of internal resorption, they're usually asymptomatic until it has perforated and become necrotic and detected through routine radiographs, as it is commonly asymptomatic and common in maxillary central incisor, because most in case of traumatic injuries, central incisor, maxillary central will be involved. Usually single tooth, but it can also involve multiple teeth, and granulation tissue manifests clinically as a pink spot. That is peculiar clinical finding. Then internal resorption can be again divided into replacement resorption, internal inflammatory resorption. Replacement is actually rare when compared to inflammatory. Inflammatory is the most commonly seen kind of internal resorption. Now, there are various factors, etiological factors for internal resorption, like traumatic injury, long-standing chronic inflammation of pulp, luxation injury, iatrogenic injury, then crown preparation, deep restorative procedures, the application of heat over pulp, that is pulpal irritation. Basically, it is pulpal irritation. And there can be idiopathic causes as well. Then coming to the categories of internal resorption, that is replacement and inflammatory. First one is the internal replacement resorption. It's also known as metaplastic resorption, because something is lost and some tissues, metaplasis can occur. That is, some tissue is replaced by some other tissues. So that is why it is known as metaplastic resorption. So in this kind of resorption of dentin with subsequent deposition of hard tissue, that is why it is dentin is lost and it is replaced by another kind of tissue, that is bone tissue. Deposition of hard tissue resembling bone or cementum or osteodentin is formed. So this occurs mainly due to low-grade irritation to pulp, and damaged pulp tissue is replaced during healing process. Tissue metaplasia may take place. That's why it is known as metaplasia takes place. That is why it is known as metaplastic resorption. So root gradually will be replaced with bone. So in the image you can see the root canal, which had undergone some irritation, maybe due to some luxation injury or subluxation injury. So there will be loss of some tissues which are replaced by hard tissues, which resembles more of bone, cementum or osteodentin. So that is why it is known as metaplastic or replacement resorption, internal replacement resorption. So etiology can include trauma, chemical burns, pulpotomies. Then clinical finding, usually it remains asymptomatic. And if at all ankylosis occurs, infraocclusion of tooth can be a finding. Then radiographic finding, there will be enlargement of canal space. Then space later gets engorged with material of radiopaque appearance, and there will be mottled or clouded appearance in that metaplastic area. That is a radiographic finding. And histopathology, replacement of pulpal tissue by periodontal-like connective tissue. Then treatment is endodontic intervention. It is a treatment of choice for internal replacement resorption. Now coming to the second kind of internal resorption, which is very common, that is internal inflammatory resorption. So here progressive loss of dentin will be present, but without deposition of any hard tissues like metaplastic. So etiology includes trauma, caries, periodontal lesion, vital root resection, excessive heat generation, then cracked teeth. All these are etiological reasons for the inflammatory resorption. Then clinical feature, often it is asymptomatic. Extensive resorption of coronal pulp results in pink discoloration. So it is known as pink tooth of memory or pink spot. Then in active stages, bacterial contamination of pulp results in signs of pulpitis with pulpal necrosis and establishment of bacterial colonization. Signs of apical periodontitis can develop. And progressive lesion can lead to fracture of teeth according to Engel. So all these are the clinical features for the internal inflammatory resorption. So radiographic finding, you can see a round or oval radiolucent area in the central portion of teeth. So it will be, since it is an internal resorption, it will be within the tooth. That is, root canal will be having a bulged out appearance. The root canal will be enlarged. You can see. And histological features include pulp shows chronic inflammatory reaction, periodontal and odontoblast layer will be missing. Then resorption lacunae will be occupied by odontoclast. All these are the histological features. So coming to the management, so it can be of two types, non-perforating kind of lesion and perforating kind of lesion. In case of non-perforating lesion, pulp removal and canal preparation is a treatment option. Removal of all inflamed tissue from the resorptive side, ultrasonic activation of the irrigants allows better access to resorptive sites. Then combination of sodium hypochlorite irrigant and calcium hydroxide as intracanal medicament can be used. It was proposed by Strong et al. In Endodontic Dental Traumatology article. So obturation, since it is difficult to obturate because the root canal morphology has been changed. So you can use a thermoplastic obturatory method like Obtura 2. Then all this method can be used according to Goldglue et al. Then perforating lesions, it can be non-surgical management and surgical management. In case of non-surgical repair, after cleaning and shaping, calcium hydroxide can be given as intracanal medicament for barrier formation. Then patient should be recalled frequently after 3 months for confirmation for barrier. Then after barrier formation, you can obturate it like the non-perforating lesion. You can use Obtura 2. Then MTA can be used as perforating repair material. Then hybrid technique can be used. That is, canal apical to the lesion can be filled with GP and remaining with MTA. Then in case of surgical, that's perforation repair, surgical management, you can raise the flap. Surgical flap is raised, detect the exposed site. Then the inflammatory tissue should be curettaged, cleaned and restored with adhesive materials like GIC composite, or you can use MTA. Then obturation should be done with GP. Then root resection, it is an option if defect is apical third is an apical third, root resected, apical root defect, and retrofilling can be done using any retrofilling material like MTA, Biotin, or GIC. Then in case if the defect with minimal, if the defect is very minimal root damage is has been occurred and it is an inaccessible area. So in that case, you can do an intentional replantation. So all these are treatment options for perforatory kind of inflammatory resorption. Now coming to the second main category, that is external root resorption. So it is initiated in the periodontium and affects mainly the external surface of the root, unlike the internal resorption. So it affects the external surface of the root. And according to Gutmann, it is divided into external surface resorption, external inflammatory root resorption, and replacement resorption. So the main causative agents or etiological factors for external resorption include periodontal disease, luxation injuries, hyperparathyroidism, then Turner syndrome, Paget's disease, Gaucher's disease, and following radiation therapy. All these are etiological agents or reasons for the external resorption. So first kind of resorption, that is repair-related resorption, that is surface resorption. So it is not very common. It is actually a repair-related resorption. There is no need of any treatment for this. It is characterized by small superficial resorptive cavities in the cementum and the outermost layers of dentin without an inflammatory reaction period. And as I said, it is transient phenomenon. There is no need of any treatment. Then represent the healing process to chronic or acute injury in the PDL affecting the cells adjacent to root surface. Etiology can be luxation injuries like concussion, subluxation, or lateral luxation. Intrusion and replacement, intrusion or replantation of Owl's teeth can also be an etiological factor for repair-related resorption or surface resorption. And root fractures can occur sometimes. Chronic injury to PDA like ortho treatment, traumatic occlusion, and followed by cyst or apical granuloma can also occur and can be an etiological factor. Then clinical feature, no significant signs of external resorption is detectable. Actually, there won't be any signs. Then radiographic find temporary wide, that is transient. Since it is transient, there can be temporary widening of canal, resorptive sites. It's not detectable, very much detectable in radiograph. In pathogenesis, this injured tissues are removed by macrophages and osteoclasts. When trauma or pressure, that is traumatic injury or pressure from a cyst or an impacted tooth, this discontinued spontaneous healing can occur. That is why it is not as repair-related resorption. And new cementum formed with insertion of PDL fibers. So management, there is no need of any management. Endodontic intervention is not indicated. When trauma or pressure, there is a causative agent is eliminated, usually 100% repair can occur. It is a surface kind of external resorption. It is repair-related resorption. Now coming to the second one, external inflammatory resorption, which is very common and which is very destructive. It represents a combined injury to pulp and PDL. Bacteria primarily located in pulp space and in dentinal tubules trigger osteoclastic activity on root surface, and it is a rapidly progressing kind of resorption. It's very difficult to control. So etiology is acute trauma, common after intrusion and replantation of Owl's teeth. So histological features, you can see a saucer or bowl-shaped areas of resorption, both cementum and dentin, and inflammation adjacent to PDL membrane can be seen. House-shaped lacunae occupied by abundance of osteoclasts can also be seen in histological finding. Then clinical features, negative response to pulp vitality testing, increased mobility, dull percussion tone, tooth extrusion, and sinus tracts can be visible. So you can see the picture, bowl-shaped resorptive changes can be seen, which is very destructive, and it can progress rapidly, which affects the whole external surface of the root, and it can affect the root canal. Then radiographic finding, it is diagnosed, usually diagnosed 2 to 4 weeks, around a month after injury. Then progressive cavitations involving root and adjacent alveolar bone can be seen in radiographs. Total loss of root structure in a very few months, since it is very rapidly progressing. Then treatment goal is to remove the bacteria to arrest the resorptive process and to allow healing process to take place. There is a main goal that RCT should be initiated as soon as it is diagnosed. And if it is immature teeth, if it is having an open apex, then apical barrier should be formed and then it can be restored. You can use an MTA. This is an example for external inflammatory resorption. So in radiograph shows initially that damage was not very evident. In the second image, that is B, you can see a radiolucent area, bowl saucer-shaped radiolucent area, which is shown by the white arrow mark. Then the third image, it has rapidly increased, and in the final image, it has almost touched the root canal system. So this is the external inflammatory one, which is more common and more destructive. Then third one is a replacement resorption. So teeth become part of alveolar bone remodeling process. So this can be transient as well as progressive. If it is the injury size is very less, that is around 1 to 4 mm square, it is transient. And if the injury size is more than 4 mm square, it is usually progressive. So etiology include trauma, which includes severe luxation, intrusion, replantation of Owl's teeth. Then clinical finding, tooth appearance is replaced. That is, the tooth has become alveolar as a part of alveolar bone. So it's a kind of ankylosis. So tooth appears firm in the socket and you can hear a high metallic sound on percussion. Then radiographic findings, more than an appearance with irregular border, then absence of PDL and laminar dura, because there is no PDL between the tooth and the bone. This tooth root has fused with the bone. So there will be absence of PDL and laminar dura. The treatment, actually, the treatment options include decoronation. That is, it is suitable for young children and adolescents, because decoronation, if you remove the crown portion, leaving the root, you can later, for the children and young adults, you can later place implant. That is, removal of crown, leaving root allowed. It also helps in the growth of alveolus, vertical growth of alveolus. Then this replacement of root can be done with the implant placement later. So that is a first option, decoronation, then luxation of the tooth after breaking the ankylosis site, then vertical distraction, prosthetic elongation. All these are the treatment options for the replacement resorption. The next kind of resorption, which is different from other kinds, which I have discussed, is external cervical resorption, or it is also known as invasive cervical resorption. So according to Cohen, external cervical resorption, or ECR, is a form of root resorption which originates on the external surface of root but may invade root in any direction and to varying degrees. Usually occurs immediately apical to periodontal attachment in tooth with periodontal disease, more apical to an apical location. That is, if it is a periodontal diseased tooth, you can see the location will be more apical. So etiology, 23% orthodontic treatment, 15% trauma, cervical restoration in case of 14%, then bleaching of non-vital teeth. As we all know, bleaching of non-vital teeth, the main complication is a cervical resorption. That is around 5% cause will be the bleaching of non-vital teeth. That's intracoronal bleaching is also a cause for the invasive cervical resorption. So Harsha has classified the invasive cervical resorption or external cervical resorption to 4 types. Class 1, 2, 3, 4. Class 1 is small invasive resorption lesion near the cervical area. That is, cervical area, there will be resorption, but there won't be much penetration to dentin. That is a class 1. And the class 2 is well-defined resorptive defect close to coronal pulp. See the second one. Class 2 is more closer to the coronal pulp. Whereas third one is more worse than class 2. That is deep resorptive lesion involving coronal pulp and also coronal third of the root. The fourth one, resorptive defect extending beyond coronal third of the canal. That is a fourth one. Harsha classification of external cervical resorption. So clinical finding, early stages will be asymptomatic. Invasive lesion show pink spot next to cervical margin, and if perforates enamel and dental gingival margin, gives appearance of mild gingival hyperplasia, and there will be loss of periodontal attachment at the site of resorption. So in that clinical image, we can clearly appreciate that pink color in the cervical area. And profuse bleeding and throbbing due to granulation tissue can also occur. Then radiographic finding includes cervical bowl-shaped lesion. In that cervical area, you can see a bowl-shaped radiolucency, pulp canal not invaded in initial phases, but if it is not diagnosed, it can sometime invade. So management, again, in non-perforation cases, mucoperiosteal flap is raised. Then mechanical debridement, then cavity treated with 90% trichloroacetic acid. Andaman enamel and dentin can be removed and cavity restored with agents like GIC composite biodentin, and flap is repositioned. This is a management for non-perforation cases. But in case of perforation cases, we'll have to do AO, axe opening, then canal preparation, saline can be used as irrigant. Then a GP point with Vaseline has to be placed in canal to maintain patency. Then surgical treatment done, which includes mechanical debridement and restoration. Then flap reposition, then root and RCT can be done. So this is a treatment option for perforation cases. So this is the table showing difference between external and internal resorption. That is, internal, you can see the margins will be smooth and clearly defined, whereas in external, borders will be very irregular and ill-defined. Then root canal walls appear to balloon out in internal, whereas that findings are not evident in external. Outline of root canal is distorted in internal, whereas it is normal in external. Root canal and resorptive defect appear continuous, whereas in external, it is root canal is seen running through the defect. In case of internal, radiolucency confined to root does not involve bone. External almost always accompanied by resorption of bone because it mostly affects the external surface of the root. In internal, bone lesion is seen only if resorption perforate tooth, whereas in external, radiolucency appear in root and adjacent bone. Then in internal, resorption lesion appear close to root canal in different angulation, whereas in external, lesion moves away from the canal as angulation changes. So this is very important. This table shows the difference between internal and external resorption. So to conclude, tooth resorption is a perplexing problem where the etiological factors are vague and less clearly defined, and usually patient is asymptomatic. That is the main problem. And for the best treatment outcome, the clinician should have a very good knowledge of the etiology of resorptive lesions. And early diagnosis and prompt treatment in such cases are the key factors which determine the success of the treatment. So that's all. Thank you.